All right. Welcome, everybody. We've got a really great topic today. We are joined by Thom Dahle out of Minnesota. Thom is the director of valvular heart disease at Centricare Heart and Vascular Center in St. Cloud, Minnesota. Thom is a stud. In addition to his accolades as an interventional cardiologist, he has numerous very cool side hustles, including owning the biggest axe throwing bar in Nashville, and a great consulting company focusing on medical innovation. So he's going to talk to us today about transitioning to nurse-led sedation for your TAVR procedure. So welcome, Thom, dude. It's good to see you, man.
Well, thanks, guys, for having me. I think this is a great conversation to have, and it's a lot of conversations that I think a lot of us want to have and are having right now, not only within our own group, but with other groups and also with our anesthesia partners. So thanks for having me.
Awesome. Well, Thom, I think it's clear that with the anticipated growth of structural heart, everyone's saying it's going to go up 100% in 5 years. We are going to have to improve our throughput for patients in the structural heart space. And I think that, the only way to do that outside of bouncing between two labs is to transition to nurse-led sedation. But I think a lot of people are scared to do that. A lot of people like the way things are and don't want to change. So I was hoping you could just tell your story about what you guys did in St. Cloud, transitioning to nurse-led sedation, and give us a little background on what that experience was like.
Yeah, I think I can sum that up pretty quickly. When we started doing TAVR years ago, we started in our hybrid OR, which is physically located on a different floor from the rest of our cath lab and our other department. And we always worked with our anesthesia partners in the OR. Eventually, the volume that we did in TAVR, and frankly, the volume we did in the hospital, just of all OR cases, OR, cath lab time, everything became, a very tight commodity. And so we began the discussions of moving moving TAVRs up into the cath lab, which it was a little bit easier to control. We had a little bit more availability than our hybrid OR. And that's really where the discussion kind of started to begin, because it was a harder resource for anesthesia to cover, being located on a different floor. And also it changed the throughput for anesthesia on how to cover these cases when we were physically in the OR, going to the PACU after, things like that, versus now in the cath lab, coming from our pre-op area in the cath lab and going back to our cath lab recovery area, rather than going down to the PACU and sending the patients kind of all over the hospital. And so that's really where the discussion started. And then fast forward, I think it really got pushed to the forefront with COVID, and as anesthesia resources got stretched even more thin with cases and how to cover this, we kind of continue to ignite the discussions on where to go. And I think the big other catalyst is, as we move forward in TAVR, really kind of this minimalist approach to TAVR, such as the benchmark program with Edwards Life Sciences, and some of the things that all of us had been part of as a community to try to minimize the patient impact, improve patient recovery, and help utilize resources better. We started talking about nurse-led sedation and how we could simplify this.
Got it. Yeah, did you guys do this through Benchmark, or was this separate from Benchmark, and Benchmark was kind of the catalyst?
This was kind of a little bit before Benchmark. So this was kind of a hybrid at the same time. We had been part of the groups as far as talking about nurse-led sedation and where to do this. I think pre-Benchmark, led us to moving up into the cath lab and simplifying that approach. And then working through this process, it's one of these things that just really kind of clicked with our program, that it just ultimately made sense. When we started it, there was a lot of resistance initially. There's a lot of people who are scared to do it, honestly. There's concern from our cath lab staff, concern from our other physicians, and concern even from anesthesia. But we started to look at, once we kind of switched how we looked at TAVR patients, and we looked at them more simplistically as, it's what do we do for patients who are in the cath lab? Oftentimes, a very complex high-risk CTO and pellet procedure can be much more complex than a straightforward TAVR.
Yeah.
And once we started kind of looking at, well, what do we do with all our other patients? Why do we do it differently for TAVR? And we started talking about the goals. The biggest thing I think with talking with anesthesia was, what was the goal of the patient? Was the goal to have the patient completely out, not moving? Was the goal to have the patient comfortable but awake? And once we kind of re-looked at the goals of what we wanted for our patients during TAVR, that kind of helped drive the discussion as far as how do we accomplish that goal and what resources do we need to accomplish it. And once we started looking at it that way, rather than, oh, is this an anesthesia patient? Is this not an anesthesia patient? That's when the discussion, I think, kind of opened up a little bit more, when we centered the discussion around the actual patient goal of care. So.
I love it. No,
Did
that's
you
awesome.
start with the anesthesiologist involved pretty early to try to make sure they kind of bought into it, or?
We did. They were part of this discussion the whole time. Because we had anesthesia was with us when we transitioned from general anesthesia TAVRs to
Sure.
more conscious sedation to very light sedation to no sedation, and so they were part of this the whole time. And when I would say that we first kind of made the jump to this minimalist TAVR approach and optimized our TAVR program before we made that jump to nurse-led sedation, if that made sense. And anesthesia was part of that journey the whole time with us. So once we got to that point where our patients had, our goal was no longer completely out and not moving, to a minimalist TAVR approach with very simple skin prep, ultrasound access, comfortable patient, minimal sedation or no sedation, it became to the point where anesthesia was like, well, you guys don't need us here. What are we doing here?
Right.
I'm standing here in your case and not giving you any sedation or giving 50 of fentanyl. I mean, they almost started to drive that, that discussion as well, as far as, are we the right people to be here for this, given that the goals of TAVR has changed?
Yeah. It's funny, Tom, when we did Benchmark, we moved from the hybrid OR to the cath lab, which I think is a game changer in and of itself, especially if they're geographically in different locations, because when it's in the hybrid OR, the patient goes in that workflow, kind of the OR workflow, which is, at the end of the day, like you said, we're putting a big stent in, a focal lesion. That's kind of what it is. And so our anesthesiologists stayed on board, though, and now they're right back to where they started, gorking our patients. Like, I had to convert 2 patients to GA yesterday because they were jumping off the table. And so I think that's interesting, that if you're going to move the cath lab and just do nurse-led sedation. Just knock out 2 birds with 1 stone with that. I think that's brilliant. Can you talk a little bit about some of the benefits that you've experienced once you've transitioned nurse-led sedation, in terms of both the patient experience and your kind of throughput?
Yeah, I would say, from a patient standpoint, we clearly defined the goals with anesthesia. So whether or not it was anesthesia-led sedation or nurse-led sedation, our goal and outcomes were essentially the same, because we wanted a patient, first of all, what we want a patient who's awake, cooperative, able to talk with us, able to follow commands, but we want to make sure they're comfortable. And so that was the main goal. The benefit of that for us is, just for that goal, is the patients recover quicker, they get out of the hospital soon, they mobilize quicker, they feel better. And then specifically to nurse-led sedation, it just helped increase our throughput, because it was very difficult for anesthesia in the location and the coverage to come all the way up to the cath lab and cover that. And when we have a single nurse, it's very easy. Basically, our throughput, our turnaround time, honestly, is about 15 minutes.
Wow.
As soon as we're done with the patient, they get them back in the bed, the nurse brings them to the unit, the other nurse accepts that patient there, and then that nurse literally picks up the next patient and brings them right back to the cath lab. And so we don't have that lag time that we had when we had anesthesia. And part of that wasn't their fault because of the geographical location. And also, anesthesia flexes their teams throughout the day. And, we had an issue where you might have 3 different CRNAs for a 30-minute procedure, versus, a dedicated nurse who follows the team the whole day. They break when we break, the team breaks together, and they come back together, versus all this kind of separate break and switching and, morning person versus afternoon. We just have our nurse that stays with us until we're done.
Yeah.
And so that was a huge benefit. I would say the biggest benefit to the specific nurse-led sedation is kind of the throughput and the turnover time. And then, the other big benefit on top of that is consistency. And that was a big issue for us. And I think a lot of people struggle with that. Anesthesia is covering a lot of different things throughout the day, a lot of different procedures. And sometimes we get people who are very familiar with what we're doing and what our goal was for patient care. And the very next case, you might get someone who, doesn't understand what that goal is. It hasn't worked with our team, and the patient was completely out and in a fashion that we didn't want. And so having that same nurse-led sedation, again, they're part of our team. They work with us every single day in cath lab in all our cases. So it's just like having a team member that, you're so familiar with, you know how to talk to each other, what the goals are. And so that was, other than throughput, that's one of the major benefits, is just that person who's an integral part of the team.
I love it. And I think when we talked, Tom, you said you guys can do like 4 cases by like 1 or 2 o'clock.
Yeah, typically we start at 8 a.m. So we don't start crazy early. We usually get to the lab. The nurse brings the patient in at 7:45. They're prepped and draped by 8. We usually try to stick about 8. And then we usually have 3 cases done by noon. Then we break the whole team for lunch. And this is just in one room. We don't have a swing lab. We break for lunch kind of as a team. And then usually the next patient's coming in at 12:45 or 12:30, sticking at 12:45, and we're done by, 1:30.
That's great. Wow.
Great.
Did you guys look at costs? I have to imagine there's a huge cost benefit.
We did, and I apologize, I don't have the numbers in front of me, but we did look at the total cost of utilizing the anesthesia resources versus our cath lab nurse. And our cath lab nurse is part of our daily, our daily team regardless. So they're always there. It's just whether or not they're assigned to our room or not. So, and with Benchmark as a whole, we greatly decreased our total costs of the program. And that's been a process over the last, 5 years, and been very profitable. Because of that, it's allowed us to make other decisions in the program, like, and this is a whole nother discussion, but, whether or not we want to use Sentinel on every case, which we made the decision to do because we've been a very profitable program, and we can decide where we want to use those resources. So that's been helpful.
That's huge. I mean, I think the Emory data showed it was like a $10,000 cost savings just going to the cath lab and implementing nurse-led sedation. So that's huge, dude. And then what do you say to some of the risks of not having an anesthesiologist around? I think a lot of us are maybe under the relatively false sense of security that, hey, if a patient's getting cantankerous on the table and needs to convert to GA, or if there's a complication, I will say the anesthesiologists are usually pretty quick to give vasopressors and stuff like that, but they're usually counteracting the 50 of propofol they're on or something like that.
Right.
But what do you say to the risks for, conversion to GA and kind of hemodynamic collapse and having that ancillary support to intubate the patient and support their airway at least?
I think from that standpoint, I think the risks are, they are going to be somewhat program dependent. I would definitely say that when we followed kind of the Benchmark program of more minimalist TAVR, where our patients are awake with minimal or no sedation, you almost never see hemodynamic compromise. It's rare. You can pace them much longer. Ever since we've switched to kind of this sedation protocol, you're not giving pressors. You're not seeing this. Patients immediately, as soon as you stop rebounding, are right back to where they are. When we look at, I think TAVR is one of those things, and most people nowadays would probably agree, TAVR 99% of the time goes incredibly smoothly, and when it goes bad, it goes bad. You're dealing with a major catastrophe, and if we're dealing with a major catastrophe, airways, even though it's ABCs, airways not usually maybe the first thing you're doing. You don't have the time to take time to intubate. You're doing a pericardial centesis, or you're figuring out how to bail out this patient. But just like anything we do in the cath lab that's high risk, or, complex PCI, watchment, whatever you're doing, if something goes wrong, we have that ability to call anesthesia, to call them stat, to manage the airway, and we have ways of dealing with that until they're able to arrive, just like every one of our cases. And so, that's probably most people's concern is, everyone remembers the one case that went terrible. They forget the 1,000 cases that go perfect. And it was really kind of sitting down as a group and being honest about that and talking about, okay, guys, I know we're always afraid of this, but how often does it happen? And what resource, if we don't have a resource there or not, that was a big discussion when we moved from cath lab from the OR to the cath lab was, okay, well, we're not in the OR, so is there a delay? Is that delay going to be detrimental to the patient or not? Is it going to affect patient care or not? And kind of, make those discussions from there. But I think risk standpoint, I would say the biggest risk would be not having a nurse that's comfortable or knowledgeable enough. You really don't want to get in a setting where your cath lab nurse is doing this deeper sedation. The reason nurse-led sedation works really well for us is we are very minimal, light to no sedation, very similar to what you would expect for an angiogram or a PCI. That's what your nurses are trained for in the cath lab. That's what they're used to. I think the biggest risk is if you're trying to ask your cath lab nurse to do something they are not comfortable with or push the limit of what they don't do. And that's more important for the nurse-led sedation because CRNAs and anesthesiologists, they're used to the whole gamut from nothing all the way to, complete general anesthesia. But you got to remember your cath lab nurse is not an anesthesiologist. So you have to make sure you're not pushing them or asking more from them than what they would do. So you got to make sure your goals are really in sync and in line.
Do you have specifics that you give in terms of meds, like any kind of protocol, or are you just like, hey, just treat it like a cat case?
Well, all of them, again, when we started this, we started with one nurse, only one nurse who did it. And then slowly that nurse helped train a second nurse and a third nurse. And now all our cath lab nurses actually can be in this role and we're fine with them. Generally, again, we do 0 sedation to a half to 1 milligram of Versed, maybe 50 of fentanyl. But we start slow and we usually don't do much. And I think a real big key, and this is more on the implementation side, but a big key to that is communication with the patient. I know we've talked before, one of the things our nurses are really good about is if you're going to keep the patient more awake in TAVR, you have to communicate with them. And they're always one step ahead of us saying, okay, the doctor's going to numb you up now with some Licaine, might feel a pinch. When we're going in with the big sheath, they usually quick whisper in their ear, you might feel a little pressure now when they go down on the with the sheath in there. And the nurse has done that, which is really nice rather than the doctor trying to yell over because, some of these patients can't hear very well and other things. But so they usually prep them for each stage of the procedure. And, the only next critical stage is when you're deploying a valve and our nurse right before we're getting ready to deploy and we're getting things aligned, they usually, check on the patient and say, hey, you may feel a little funny here. This is the part I told you about. You may feel a little funny for a few seconds, just try not to move. And as long as you kind of reorient the patient and kind of make sure they're awake and understanding, then you don't have an issue. What you don't want and what is really frustrating for the operators is this kind of, too much sedation kind of in between where the patient's like half asleep, half waking up. And then, suddenly you put the sheath in and they wake up and they get startled and they move and then everyone freaks out because they're moving. Same thing with putting in the valves. So, having that constant communication with them is very helpful.
Wow. So you keep them pretty light.
We do. There's some
like a German TAVR.
What's that?
It's like the Germans do it.
Oh yeah.
And you haven't had issues they're awake and then all of a sudden they're just they're moving when you're deploying the valve or something. Like it's really.
No, one of the things that's very helpful when we started doing this, and I would recommend this to programs to do it the same way, we actually used to document it. Our institution, we still do pre-coronary angios. I know a lot of people do CT coronary angios as well, but we still do coronary angios on the majority of these patients. One of the things we did when we started is we would do the coronary angiogram with no sedation, or again, like TAVR, either absolutely none because we'd want to talk to them, or very, very, very minimal at the time of cath, and we'd see how they were on the table. And we used to actually comment it in our cath lab notes, on pre-TAVR patients, that patient did great, no sedation, or patient had a lot of trouble laying flat, their back hurt, blah blah blah. And then we knew, gosh, this might not be a good one for nurse sedation, things like that. So when you're starting off, it's helpful to kind of get those clues up front about, yeah, this patient does great with no sedation, or, this patient was all over the table. That's not going to be the one you want to try for your first nurse sedation. We've been doing this long enough now that we stopped putting that in our cath lab notes, just because basically now we assume everyone did the cath fine unless we note otherwise. And, maybe 1% of patients who didn't tolerate a cath laying flat, we would put that in our notes. So we'll look for that, but we stopped putting in that they all did great.
So how many cases have you used in anesthesia? Have you used as an anesthesiologist at all since you started doing this?
We haven't used an anesthesiologist probably in 3 years.
Oh my gosh. Wow. That's amazing.
So are there any patients you don't do, or, valve and valve? Is there anything where you're like, well, we should always, let's have anesthesia there? Or like high risk cases, or anybody?
Yeah, no, we don't. We do everyone. The only ones that we do, so we do all our perc acts. We do perc acts. We do all those awake without anesthesia. The only patients that we use anesthesia is when we do transcarotid. Okay. We do GA and anesthesiologist, and when we do transcarotid, that's the only patient that we'll do.
And that's in the OR anyway, so it's really
that is in the OR for us. Yep.
Yeah.
We're trying to get that up in our cath lab, but it's there is some challenges with that.
I love it. Outside of so we'll get into implementation in just a sec, but from the operator's perspective, are there any technical differences in how you had to perform the procedure going to nurse-led sedation? Because I remember in Benchmark, David Wood used to say that we're underutilizing lidocaine to numb up the big sheath side. And so one thing I learned from him in Benchmark is to give like 20 cc's of lido, and to make sure you're getting a nice wheel on ultrasound over the artery, like actually create like a lidocainoma.
Yeah.
And that makes the whole procedure a lot easier for them. Have you integrated that, or technically is there anything different?
Yeah, I would say, we learned the same thing from David, and that was probably one of the best things we learned back when I first went to Vancouver, and this was like way pre-Benchmark days. That was back in the days where, I'll be honest, we didn't use ultrasound for access, and learning that from David was just changed our whole program. And ever since then, I think the biggest thing, and this has now translated to all access that we do, whether it's transfemoral or radial, we all visualize whatever artery or vein we're sticking, and we always visualize with ultrasound as we give lidocaine. And our goal is always to go right down on top of the vessel, inject lidocaine, just like you said, almost like a lidocainoma. Except we never give 20 cc's. Usually we're okay with 10 cc's because you're right on the tract and you're right on the vessel. And I love to see the lidocaine just wrap around the top of the vessel. And we do that for every, intervention case we do now. It's just become such a force of habit, and it works so well. And like you said, that's a real key thing, rather than blindly just putting lidocaine in the groin and then hoping the patient's not going to have any pain.
Yeah. No, I love that. I think that's a huge tip. Since I've started doing that, really, the patient comfort level, and even after the procedure, they're more comfortable, right? Because like the artery's a little more numb, because sometimes they'll feel the perclose, and if you get the artery well, they don't feel
Yeah, we do that. We do that for radial access too. Just all our diagnostic radial cases now are just all ultrasound and anesthetize the vessel when you do it.
I think it'll also improve your ultrasound skills, right? And just
it does.
It's just a nice way to do that. But
yep.
I love it. So so my mind's made up. I'm gonna do nurse-led sedation. How do I have my biggest concern? How does that conversation with the anesthesiologist go? Because like they're gonna be like, what? Like we were doing 5 cases a week. You don't want us there anymore? Like how do I broach that topic with them? What are your recommendations for managing anesthesia?
I think the way to manage that first is, again, to do the minimalist approach first before switching to nurse-led sedation. So make your anesthesiologist, and hopefully there's some anesthesiologists on here and they can yell at me. make your anesthesiologist bored first. Make them bored out of their mind because they're not on your cases. Once they're bored out of their mind because they realize, man, they're just not doing anything, and it's just they have so many other things they could be doing and we should be doing, and people are waiting for them, and anesthesia, at least for us, is a super scarce resource. I mean, they are pulled in so many directions at our hospital. So we just made it so that they're like, it just makes no sense for me to be here. And then that conversation about nurse-led sedation was very easy because we're like, hey, should we just do this? Because we do the same thing. I mean, we do no or minimal sedation, just like a cath for us. Are you okay with us doing it? And surprisingly, it was a real open conversation, and it was almost something that they wanted because they do know how much they're being pulled in other directions. But the important part of it was the discussion about, okay, well, what do you guys do if something goes wrong? Or, I mean, how are you going to call us? Are you just calling a code? What is it? And, we just kind of talked through that. And essentially, we don't have anesthesia on standby. It's essentially we call a code if we need anesthesia, just like if we were doing a STEMI in the middle of the night that, didn't start doing well and we needed to intubate them, we call for anesthesia. And they're incredibly fast to get their CRNA or anesthesia, as they're usually on call for the whole hospital. And it was just kind of working through that workflow of what we expected from them. And once we had that discussion that it's no different than, having a STEMI that comes in that suddenly goes sour, that we're going to call you the same way. Everyone was pretty much on the same page.
I love that. And I love the analogy. Like, it's always shocking to me the stuff we get away with in the cath lab without anesthesia that doesn't involve TAVR. All like the high risk PCIs, and I mean, STEMIs are a perfect example. The fact that we do STEMIs without anesthesia, it's just fucking crazy sometimes.
Those are the sickest patients, and we don't have anybody, right?
They're trying to die constantly, and like it's just
no blood pressure, and
I mean, sometimes they're being bagged when they come in, and back to the whole. Sometimes you're going to STEMI that's coming in hot, that's in shock, but you're not going to pause and do airway first. Right. You're supporting them a little bit while you either get, hemodynamic support in, or you're, at least getting your guide and stuff in. And once things settle down, that's when you're having anesthesia to come up and pause and intubate and take the time. We're usually kind of holding them out of the room for a little bit.
Right.
And it's no different when a TAVR goes wrong.
Sure. So you've had the conversation with anesthesia, you've gone minimalist, and they feel superfluous. And so you say, hey, maybe we'll just have a contingency plan in place. And then people feel so comfortable with protocols in the hospital. They're like a warm blanket for nurses and administrators. Like, do you feel like, is that even necessary? Because like in your experience, it's basically like, we're just going to do this, and you do it. But do you think it's helpful when you start to have some sort of protocol for the nurse to adhere to, maybe even like a script, like at this step, this is what you say? What's your
and the biggest thing for us was instituting that protocol as far up the line as you could. Because this, again, it's hard to separate nurse-led sedation from minimalist kind of approach, or minimalist sedation kind of go hand in hand. I wouldn't recommend doing nurse-led sedation unless you're doing minimalist kind of approach and sedation. And for us, it was making sure that there was clear messaging across the board, because all it takes is one nurse or someone to say, yep, you won't remember, you're going to be snowed out of your mind. And if they say that, the patient's expectations are totally blown. And when they come into the room and they start going, what? I'm not going to wait, what's going on? I'm not asleep, So for us, it starts from our valve coordinators who meet with the patients, our pre-cath area, all those nurses knowing what we're doing, understanding the purpose, the reason, the how, and the why. And also, as physicians, every patient we go in and see, and it's also kind of educating the family, because you go in to talk to the patient, we consent them, and every one of us gives the same spiel that we're going to give you as much or as little sedation as you need. And just so you know, the less sedation we give you, the better you're going to do, the quicker you're going to recover, and the better you're going to feel. And we give, all of us docs give that same spiel, all the nurses give the same spiel, and we kind of flip it on the heads, because all these patients, everyone wants to be asleep during their procedure. But once we keep on giving the message that, listen, the less you're asleep, the better you're going to feel, the quicker you're going to recover, and the faster you're going to go home, they're all like, great, sounds great. But if you have one person that comes in there and says you're going to be out, you're not going to remember a thing, you're totally hosed. I mean, there's nothing you can do at this point.
What does it feel like to get rapid LV pacing? Have you tried it on yourself? What do they tell you? Is that something you should do? It's just like
well, I mean, after a few nights of maybe too many cocktails, I probably know what it feels like.
But do they say anything? Do the patients say, "Well, yeah, I felt a little lightheaded," or is it just they don't really...
some of them absolutely don't notice anything. Some of them, say, "Oh, yeah, I felt that." But again, like we've never really had, I mean, in hundreds of cases, with good planning, making sure they're comfortable and communicating with the patient, we've never had someone like suddenly try to jump off the table or move or do anything crazy. Usually they usually don't say anything other than, "Oh, I felt a little fluttering," or maybe "I felt a little lightheaded." And we've even had those patients that, you have difficult positioning and you have a prolonged pacing run. Usually if that happens, they actually become a little bit more apneic or less aware. And then when they wake up, they could maybe move. But at that point, your procedure's done, you're controlled. You don't have, it's not as critical as doing it during the pacing run. But
they get to say hi to their dead relatives if they pass out, right? They see the light and then they come back. It's got to be fun.
Most of our patients comment, we've had a couple patients be like, "Oh, this is fun. I enjoyed all the jokes and the commentary of, staff or things. So we got to be a little careful of
what you say.
What we're talking about."
I bet.
Oh, I got axe throwing a lot. I don't know. It was weird.
Yeah.
I've had a lot of patients after go, "So tell me about this Nashville thing." I'm like, "Oh, well, you were listening."
I hate that. I do that all the time where you forget that the patients are wide awake and you're talking to your tech and you're just like, "Oh shit, I probably shouldn't have said that with the patient."
Yeah.
I love it. Well, Thom, that was amazing, dude. I'm inspired. I'm totally inspired to do this. I think throughput's so, I mean, at the end of the day, it's a work-life balance thing too. If you can get the TAVRs you need to get done in a timely manner, get home to your family, you're not stuck waiting for anesthesia to turn over. I think patient care, it's better cost. It seems like really kind of a win-win-win for implementing this, and super, super valuable discussion. Raney, did I miss anything, bud? Any questions you have? Are you going to do this at St. Joe's now?
Anesthesia has never been a pain point for me, but just talking about this, it's definitely something to consider. I know our anesthesias, they're great. They're there for the cases. They're quick. Nothing negative, but they are becoming a scarcer resource, and we need them for other procedures where you have a TE probe down. So as they become more scarce and tougher to get, I think it's definitely something to consider. So it was great to hear about it.
I love it. Well, Thom, thank you, buddy. Any closing words of advice to kind of how do we start generating some of these side hustles that you've done? Is that something that?
Yeah. How did you get the axe throwing bar? What's the story there?
Oh boy, that's a longer conversation, but actually that was watching TV at night. I think it was a Christmas Eve with my entire family and all my relatives, at 1 a.m, and we were kind of looking at business ideas. I said, "Well, we can do that," and then next thing you know, 3 years later, we have one open in downtown Nashville. So
wow,
the biggest one in downtown Nashville.
That's the biggest one. Yeah, it's probably the biggest one in southeastern United States. So
man. When are you gonna retire? Is that your exit strategy, or do you?
No, I don't know yet. So I have too much fun with the team. It's always fun to be part of all this new technology and everything else. And just like what we do here at work, for me, what we did down there it's team building. It's fun. It's totally different. No one's gonna die unless you hit them with an axe, but
I love it.
But it's just different team building, and it's similar to what we do. It's customer service. It's making sure you have a good product. It's making sure you have people have a great experience, and it's amazing. It taught me a lot about how much translates into medicine, and what we do is often sales and taking care of people and delivering a good product and doing it in a high quality fashion. And it's very similar. I mean, it's just a different product.
I totally agree, dude. I mean, just entrepreneurial skills in general are such valuable life skills. So I would encourage any docs out there to consider doing stuff like that, because they feed each other, right? Being a good doc makes you a better entrepreneur. Being a better entrepreneur makes you a good doc.
Yeah. And it's just like you. I mean, it's a creative outlet for us. So I mean, so it's something completely different. than what we do on our day-to-day. It's a completely different mindset when I'm down there. The problems you face and overcome are completely different than the problems we face in medicine. So it's just a different side of the brain to use.
Yeah. I'm Irish, so I could never own a bar. I would.
Yeah. Walsh would be in trouble with that one, man.
That's why I own one in a different state. I couldn't.
Okay, there you go. That's an option for you, Joe.
I love it. I love it. Well, Thom, thanks so much, buddy. Have a great week, and we'll follow up with you, let you know how this is kind of gotten through the community, and hopefully we can get people posting on Murmur about their experience implementing this, and we'll put this on the Benchmark channel and get this out to the Benchmark site. So thank you so much, buddy. I really appreciate it.
Yeah, no problem. Thanks for having me. And, I hope everyone, again, I think this is really program specific. If you have a program where you have the ability to have an anesthesiologist on every case doing minimal or no sedation, that's great. But I think it's really program specific, just like a lot of the decisions we have to make as a program, cath lab, OR, hybrid, whatever, it's really dependent on our resources, the people that are involved, everything else. So, just because it works well for our program may not be the ideal thing for a different program. So, I mean, you don't have to feel like this is something you have to do, but it's a very good option for programs that might be in similar situations or have similar patient goals or care goals that we have. So,
yeah,
awesome.
Sounds like it's the last step in minimal. I mean, how more minimal can you get, right?
Yeah, do it in the parking lot, or go to their house,
right? Yeah,
I'll do it in the bar.
Do it in the bar. There you go. Dodge an axe and get a TAVR. There you go. All right, Thom. Thanks a lot. Thanks for
appreciate it, guys.
Thanks, bud.
Bye-bye.
Thank you.